I think, for those of you that have joined us before on this speaker series, but I think it's going to be fantastic. It's always good to have our speakers on board. Hi, Ann. How are you tonight?
I'm always paranoid that the audio and the video won't work, but
Good. How are you?
it looks like it's going well.
I know it took me a couple minutes to log in because they ask you that extra security measure of putting in your email, and I put my email in incorrectly. So happens to the best of us, I guess. Thank you, everybody, for being here. I think we're just giving everybody a few minutes to gather, including John Fogarty, which he's kind of an important little piece of the puzzle, so we'll reach him. I can't imagine that he has other things to be doing right now.
Good afternoon.
There's a voice we recognize. Hi, John. I was just quipping that I couldn't imagine why you would be busy right now, of all times.
Yes, a few things going on, but sorry I'm a little late.
No problem at all. Happy to have you here. I guess you're technically the host, so we really couldn't have done it without you.
I'm sure you would have. I'm sure you would have muddled through it.
Would have figured it out. All right, we're just gathering. As I was saying, John, we have unprecedented numbers of folks
I can tell.
checking in. Yeah, no, it's really fabulous. So with that, people will probably be joining us as we get going, but just in the interest of time, because we have a lot of great information to share with you this evening, I just want to welcome everybody to the next in our wonderful speaker series, where we've covered topics in the past, such as women's health, navigating screen time during COVID, happy and healthy new year, behavioral health discussions, and we've had some really, really terrific topics. And tonight will be no exception, as we are covering heart health at BID Needham with Dr. Joe Kannam and Dr. Ann Riley. And I will let John go ahead and introduce them more formally in just a moment. But I just wanted to cover a few housekeeping rules for this evening. One is to ask you to mute yourself, and that will just cut back on any feedback and so forth. And because it is a large group, actually, I'm just reading my notes more carefully. Everybody actually is on mute. And so what we're going to be trying to do is use the chat function if you have anything to share. And so if you go down to your screen and just hover over the bottom bar, there's a chat. And I'm just going to chat to everybody right now. Welcome from me. So you'll be able to see how that comes up on your screen, and you'll be able to take a look at that. And then we will be recording this evening's presentation and Q&A for those people that couldn't join us this evening. And let me see if I'm going to miss anything here. We are also going to leave questions until the end of the presentation. And those questions could be for John, because he's going to give us a brief hospital update, and also for Dr. Kannam and Dr. Riley. We did ask people if they had any questions when they registered to share those with us. And so I do have some questions that I already have in hand, but if you have some that occur to you during the presentation, you can throw those into the chat and I'll do my best to accommodate them at the end, and I'll just be moderating that at the end as well. So hopefully I haven't missed anything terribly important. It is my pleasure to introduce you once again to John Fogarty, the BID Needham president, and I'll let you take it over. Thanks, John.
Thank you, Sam, and welcome everybody. It's a pleasure to see so many people turned out for tonight's presentation. I'll just make a couple of comments about the hospital. I think most of you know it's been a very eventful year for BID Needham, as well as hospitals across our Beth Israel Lahey Health System, across the country and across the world. Two significant things in our past year here. Obviously, the COVID-19 pandemic, under which our staff, our physicians, our employees at all levels really stepped up and showed remarkable courage in so many extraordinary ways, with the various surges, financial difficulties, and the disruption of our workforce and the stress to caregivers. Secondly, as many of you may know, Norwood Hospital flooded and closed in July of 2020, having significant impacts on our emergency department volume, our inpatient population, and the number of behavioral health and psychiatric patients seen at Needham. But a year has passed since the anniversary of our first diagnosed COVID patients. We have vaccinated our employees and our medical staff. We're winding that clinic down. We're reassessing our plans here at the hospital to continue to expand and grow as we become a site, not just for patients displaced by the Norwood crisis, but the greater Needham area as we continue to grow. We've had some real success in community support in the past year, a $4.3 million gift from the Trotman family, which was a historical gift at BID Needham, the largest in our history, approximately $2 million of that to support the expansion of intensive care medicine specialists in our ICU, critically important on the heels of a pandemic, and $2.3 million to create an endowed behavioral health navigator position, which is under recruitment right now, that will serve to outreach into the community and help us with the growing need in behavioral health throughout the Needham area and in our entire service area. So that said, it is my pleasure to introduce our presenters for today's webinar. Dr. Joe Kannam is chief of the Levine Family Department of Cardiology here at BID Needham. He's also a program director of the Beth Israel Deaconess Cardiovascular Fellowship program and an assistant professor of medicine at Harvard Medical School. Dr. Kannam graduated with a degree in biology from Boston University, earned his MD degree from the Boston University School of Medicine, completed an internal medicine fellowship in cardiology at Beth Israel Hospital, and he joined the BIDMC faculty in 1995 and is considered a leading authority on coronary artery disease, valvular heart disease, and congestive heart failure. Joe won the Patient's Choice Award and is listed in Boston Magazine's Top Doctors for 2019. And he was elected to our Board of Trustees here at BID Needham in 2016 and is a past member of our Board of Advisors. I think I'd also like to say on a personal level that Joe has really created a fantastic model of community healthcare in building the cardiology department here at Needham beginning in 2003. Fostering a great relationship with the Department of Cardiology at BIDMC and growing it into a state-of-the-art world-class cardiology department, which it is today. In fact, we have replicated his blueprint in many other departments throughout BID Needham, bringing great world-class specialists to our local community hospital. So thanks, Joe, for your dedication to Needham and being with us here today to share some more information about your team's efforts and to allow our patients and supporters to ask some questions too. Secondly, Dr. Ann Riley is the Associate Chief of Cardiology at the Levine Family Department of Cardiology, and she is also president of our hospital medical staff. Dr. Riley is an instructor of medicine at the Harvard Medical School and completed her medical school at NYU School of Medicine, and then went on to complete an internal medicine residency at Brigham and Women's Hospital. Following a general cardiology fellowship at BIDMC, she joined the cardiology staff in 2011. Dr. Riley's interests include the advancement of women within the field of cardiology, and she serves on the National Leadership Council for the Women in Cardiology section of the American College of Cardiology. Dr. Riley is an ex officio board member of the BID Needham Board of Trustees by virtue of her medical staff presidency. So, without further ado, I would like to hand the presentation over to you, Dr. Kannam and Dr. Riley. Thank you.
Great. Thanks, John, for that kind introduction. Yeah, let's stop there and I'll let you know when to advance. So as John stated, I arrived here in 2003. You can see this picture of me here in 2005. 2 years after I got here, we were over in the old building. It was basically me and two cardiologists that were kind of ready for retirement. And we went from that to building, which I'm going to show you very shortly. Here in 2019 is, we're here at the ribbon cutting ceremony between Don Levine and his wife, Barbara. And we're cutting the ribbon here in 2019, and we moved into this beautiful space in 2019. Next slide. So here, as I said before, it was just me and two other people, but over the last 16 years, we've really expanded quite a bit. So as John mentioned, this is Dr. Ann Riley and Dr. Megan York. They both joined us in 2010 and are both Associate Chiefs of Cardiology here. Dr. Lisa Fleming, who joined us in 2015, is also a heart failure specialist and takes care of all of our heart failure patients. Dr. Ian McCormick is the last to join our general cardiology group, who came here in 2018. And then in addition to that, we have Dr. Al Buxton, who can actually walk to the hospital from his house. He lives right around the corner, is an electrophysiologist with a national reputation. And then Mark Wires is a vascular surgeon, and Gretchen O'Brien is our nurse practitioner. So you can see we've grown quite a bit. Next slide. This is just a look at our volume over the period of the last 14 years. We've actually exploded from 2006 up to 2019. We did have a slight dip in 2020 with COVID, but we're now back in full force in 2021 and actually looking to add another cardiologist come the summer or the fall. Next. So what do we do here in Needham? As John stated, back in 2003, the vision was really, we wanted to bring kind of Boston doctors out to the community. And the idea was that, people back then would kind of drive by the hospital on the way to see their cardiologist in Boston. But we had this model of, why don't we take Boston cardiologists, plant them in Needham and have a connection to Boston and build it that way. We've done that in cardiology. We've replicated that in emergency medicine, oncology, and many of the other specialties. So what do we do here in Needham? So we spend a lot of time basically doing consultations, meeting people who have heart issues and talking to them about their heart problems and diagnosing them. We, as I talked about, Dr. Lisa Fleming, who's our heart failure specialist, will take care of people with congestive heart failure. She has a team with herself and some nurses that will manage these patients very closely. We do the echocardiograms. Here's a kind of a picture on the bottom of our echo lab, which are basically the ultrasounds of the heart, so we can rapidly diagnose people with heart problems. We do stress testing. Here's our two of our stress tests, and all types of stress tests that you might need, we can do here in Needham. Management of pacemakers. We talked about managing arrhythmias with Dr. Buxton, and then vascular disease as well. All right, next slide. Now, the other thing is that we're very, very integrated with Boston. All of us actually have appointments in Boston and work in Boston throughout the year. So if you need anything that's more advanced, like a catheterization, if you needed heart surgery, if you need a pacemaker, or some of the newer things that we're doing, such as replacing valves percutaneously, all that can be done in Boston, and then you kind of come back to us for any kind of follow-up care. We've actually initiated many years ago a rapid transport program for people with heart attacks. So it turns out the best way to treat a heart attack is to get a stent placed. And if you can deliver a patient to a place that can do a stent within 1.5 to 2 hours, you're better off getting transported. And we started this a program where we have ambulances that bring you right there. As soon as you show up in Needham, you get brought to Boston for treatment of your heart attack. So that's worked seamlessly and worked very well. Next slide. So next, I'm going to present a case. So that's just kind of an overview of what we're doing here and our integration with Boston. But I'm going to talk about a person that I met in December. We'll call him Mark, who you're going to meet. He's actually on the call. He was kind enough to let us kind of go through his case to help illustrate a common issue that can happen. And let's just talk about his presentation and how we ended up thinking about how to take care of him. So he's a 49-year-old gentleman. He has a history of asthma, and he came into our emergency room in December after awaking in the middle of the night with chest pain. It woke him from sleep. The pain radiated to his neck and to his right arm. He was nauseous, and he also had some right lower quadrant pain. So basically in his belly, right lower pain. Whenever anybody comes with chest pain, we check two things. One is what we call cardiac enzymes. If you're having a heart attack, you will actually, these cardiac enzymes will be elevated. His were normal. We also check an EKG to look for any kind of abnormalities. His was completely normal. And because he was having these belly pains, he actually ended up getting a CAT scan of his belly, and that was normal. So he was told, there's nothing acute, you're not having a heart attack, so why don't you follow up with your primary care doctor and get seen and try to figure out what's going on, which is completely appropriate. So he has a very astute wife who called me on the phone and said, something's not right. He's usually very active. He's been kind of slowing down. He's getting a little bit more winded when he goes out for exercise. So I want you to see him and talk to him and see if we should be doing anything else. So whenever I see somebody with chest pain, we're always think about, okay, what is his risk for potentially having a heart problem? He's young, he's only 49. So, it's not as common as if you were older, but we go through risk factors. So the first thing I'll always ask is anybody in your family, mother, father, brothers or sisters, anybody that has had any kind of heart issues? And generally, in order for it to kind of go down the generations, you really have to have heart issues in your 40s or 50s. If you have, a father who had, a bypass surgery or a stent when he was 80, that's actually not that uncommon, and it doesn't increase your risk for having something early in life. But Mark actually had a father who had bypass surgery in his 50s. So that actually is a risk factor for him having a problem. He said he was a past smoker, but he only smoked for a year over 20 years ago. So that's not really considered much of a risk factor. He doesn't have diabetes. He doesn't have hypertension. His cholesterol was 218, which was, slightly elevated, not terrible. And we often will do what we call a risk calculator, where we have an app where we can plug in all the risk factors. And he was actually considered low risk. His 10-year risk of having a cardiac event, meaning like a heart attack or needing something done, was only 3.5% over a 10-year period. But on questioning him further, I found out he's an avid exerciser. He ran the Falmouth Road Race in 2020. Next slide. And this is a picture of him with his medal after Falmouth. He actually does lots of exercise. He ran 2 Boston marathons and did lots of other activities where he's very fit. And he told me that when he was exercising, now if you go for a run, in that first mile when he was running, and this is a guy that will run 7 to 13 miles at a time and has run 2 marathons, he would start getting some chest discomfort and shortness of breath. But if he kept running, it would go away. So that kind of piqued my interest. And he also said that, this year at Falmouth, his times are not as good as they were in the past. He seemed a bit slower. He seemed a little bit more fatigued and winded. And that also kind of rang alarm bells with me that, hey, this sounds like this could be angina, which is, his heart's not getting enough blood and he's having some shortness of breath and fatigue. But of course, he's very fit. So he has to do a lot in order for him to kind of recognize any kind of problem. So now he's married. And next slide. This is a picture of his wife, who's the one who first contacted me. Many of you know her, Samantha Sherman. She called me and said, something's not right with him. We gotta check him out. So I'm actually thinking of making Sam one of my nurses if she leaves her current job, because she was very astute in realizing that something wasn't right, even though he went to the emergency room and was checked out. He has, next slide, 3 lovely kids, works as an IT consultant. So he and I had a discussion. Next slide. We had a choice of what to do. I was pretty certain he had what we call coronary artery disease, which was the story he told seemed to me that he might have a blockage. So we could do a stress test where you walk on a treadmill and we monitor you with an EKG, and we often will do some type of imaging of your heart, either with an echogram or a nuclear scan to see if you have a blockage. So that's one way of doing it. And that's what we call a functional test. We kind of stress your heart and we see, do you have any heart issue, any evidence of your heart not getting enough blood? Or we can do what we call an anatomic test. We can actually do an angiogram of your arteries. And there's 2 ways we do that. Up here in the upper right-hand corner is what we call a CT angiogram. We now can look at your coronary arteries by putting you in a CT scanner, and we can see if you have any blockages. This is not Mark's CT scan. So one way of doing it is doing a CT scan. The other way of doing it is doing an invasive angiogram, where we put a catheter in through your wrist and we inject dye into your 3 coronary arteries and we see if you have a blockage. And again, this isn't Mark's angiogram, but we could do a CT, or we could do an angiogram, or we could have done a stress test. Because I felt fairly certain that he had a blockage, if I got a stress test and it was normal, or it didn't look like there was a problem, I still wouldn't have been satisfied. And I told that to Mark. I said, look, if we do a stress test and you do very well on it, I'm still going to be uneasy that you could have a blockage. So I think we should do an anatomic study, either a CAT scan or an invasive angiogram. Now, the advantage of a CAT scan is that it's non-invasive. You go into a CAT scanner, you have an IV, and you have pretty good resolution, and we can see what's going on with your arteries without doing an invasive test. The disadvantage of it is if you do have a blockage and we want to fix it, you're going to need an angiogram anyway, and which case you would have to go and get the angiogram and potentially get a stent placed. So after talking to Mark, he decided, you know what, I'd rather just cut to the chase and do the angiogram. And if I have a blockage, we can possibly put in a stent. So I said, fine. So we went and did the angiogram. And this is actually a picture of his angiogram. So we're all born with three main arteries that feed our heart: the right coronary artery, what we call the LAD artery, that comes down the front, and the circumflex artery that goes down the side. The left coronary artery branches into the circumflex and the LAD artery. Now, Mark ended up having a 95% blockage in his right coronary artery. He had of his LAD artery, which is the big vessel down the front, a 60% blockage. He had a 70% blockage in his obtuse marginal, which is a branch of the circumflex, and he had a 99% blockage in his diagonal. Now, so he had multiple blockages in different areas. And that surprised me. I thought we were going to find he'd have one blockage or two and we'd be able to potentially put in a stent. Now, what he had, because he had the close to 100% blockage, what he described as what I call walk-through angina. Remember, I told you that when he began running, he would have some uneasiness and chest discomfort and shortness of breath. But then the vessels kind of wake up, and he actually felt better if he kept running. Not his exercise tolerance wasn't as good as it had been in the past, but he was able to keep going. So we had a choice now to potentially do a stent or a bypass. So next slide. So if you have a stent, what we do is we put a balloon across the blockage, and we inflate the balloon, and we leave the stent behind. So when you deflate the balloon, the stent will stay there and buttress open the artery and kind of push away this plaque, almost like the toothpaste in a toothpaste tube. When you inflate it, it squishes the plaque off to the side and allows flow through the artery. So that was one option. We could have done stents. The other option is to do what we call bypass surgery. And why do they call it bypass? Because what you do is you bypass the blockages. So this isn't Mark's bypass, but if, let's say, you had a blockage here, this vessel here, which is a vein that's taken out of the leg, would bypass that blockage. And here, this artery is then put down here and would bypass the blockage. So we decided that the best course of action for him would be actually a bypass. And why was that? Because a couple of his blockages were completely occluded. So there were two factors that made me recommend a bypass over a stent. One was two of the blockages were almost 100% blocked. So if you can imagine, if you have this wire that has to go through a blockage, if this is completely blocked, it's almost like running into a concrete wall. You can't get across there and put in a stent. Now, we have some fancy ways of getting across these occlusions, but the current thinking is that if you have several of these, you're better off just doing a bypass and going around the blockage. So we decided that. Okay, I don't know if you missed some of that, but we decided to go ahead and do a bypass in Mark. And we're lucky enough that we have surgeons at Beth Israel Deaconess who will actually do what we call a complete arterial revascularization. So they use all arteries and no veins for the bypass. And the reason that's important is because the arteries tend to last longer and stay open longer. And that's kind of a newer technique that several of the surgeons are doing, where they don't take the vein out of the leg. They use two of the arteries underneath the breastbone and an artery that's in the wrist. And then he got a complete arterial revascularization with all arteries. So it's likely those arteries are going to stay open for a long, long, long period. Next slide. So this is a picture of Mark leaving the hospital and going home. And he had a great success with this bypass surgery, and he's recovering quite nicely. So I just wanted to share that story of him, and we're going to save questions for the end. But I did want to thank Mark for letting us share his story because I think it's an important thing to know about. So I'll turn it back over to you, Sam.
Super. Thank you so much, Joe. And thanks for sharing that. I think we're going to hear from Anne now. Am I right, Anne?
Yes. Thank you, Sam. And thank you, John, for the introduction earlier. So I would also like to run through a case presentation. Mine is of a patient who I still follow. We can go ahead, next slide. So I just wanted to first make sure everyone understood what we were talking about when we said coronary artery disease. So this is just a picture. The top picture is of a normal coronary artery, and they're just tubes, to simplify things. And you can see the normal one on top with the cross section. It just looks like a circle. And then the bottom picture is of an artery, a coronary artery that has developed coronary artery disease, which basically means that cholesterol and inflammatory factors have accumulated against the wall of the artery. And on cross section, you can see that it's beginning to, significantly narrow the diameter of the artery, and then ultimately obstruct how much blood is able to get through. Next slide. Go ahead. Next one. Okay, so I'm going to talk about Susan, a patient of mine that when I met her was 54, and she had a history of high blood pressure and high cholesterol that were both treated with medication. She's married and has two children who are adopted, and at the time were 8 and 10. And she has a very busy life with those kids and her work, and she spends most of her time caring for her family. She doesn't have a lot of time for herself, and she wasn't getting any regular exercise. She was a prior smoker. She smoked for about 2 years when she was a teenager. And she also had a significant family history in that her father had had a heart attack in his 50s. Next slide. So she presented to me in clinic in Needham with a complaint of a year of right-sided arm discomfort. And initially she said this came and went at random and wasn't related to any exertion. And then about 3 months ago, she started to notice that it was her right arm and her right shoulder, and it would kind of go into her right chest. And she noticed that this was now related to episodes of exertion as well as episodes of stress, like when she was really yelling at her children. And she described a pressure that went from her shoulder into the front of her chest when she was, for example, walking up the stairs in her house or walking uphill. And when she stopped walking, like when she got to the top of the stairs or when she stopped at the top of the hill, then the discomfort would go away. And she also has a history of orthopedic problems in her right shoulder. So it was a little bit hard for her to tease out and for her doctors to tease out whether or not this was like her shoulder problem coming back or if this was something new. Next slide. So she was obese because her weight was 209 pounds with a BMI of 30. In clinic, when I saw her, her blood pressure was normal on 2 blood pressure meds, and her exam was otherwise normal, and her EKG, which I gave an example of here, was also normal. Next slide. And so I just wanted to pause for a minute and talk a little bit about the different risk factors that we consider when we see people in the office. And there on the left are the traditional risk factors, and ASCVD just stands for atherosclerotic cardiovascular disease. And so that's generally heart attacks, strokes, and severe blockages in arteries elsewhere in the body, like in your legs. So traditional risk factors include diabetes, smoking, obesity, physical inactivity, high blood pressure, and high cholesterol. And there are also a number of emerging non-traditional risk factors, ones that haven't been studied as well in the past, but are being focused on more now. And those include things like preterm delivery, developing high blood pressure during pregnancy, developing diabetes during pregnancy, having autoimmune disease, some treatments for breast cancer, including radiation, if you've had that in the past, particularly if the breast cancer was on the left side of your body, as well as depression. Next slide. And also, given that one of my interests is, in addition to advancing women within the field of cardiology, is making sure women in general know how important their heart health is for them, as well as their spouses and men in their lives. And so, women as well as men, the most common symptom that they get during a heart attack is chest pain or discomfort or squeezing in the chest. That's still the most common thing. But women are somewhat more likely than men to experience other heart attack symptoms, including upper body discomfort in the arms or the back or the shoulder, or the upper part of the stomach, shortness of breath, nausea and vomiting, breaking out into a cold sweat, or severe lightheadedness. Next slide. And so for Susan, some of it sounded like, some of her story sounded like it was, could be from a blockage. Some of it wasn't clear because of her previous shoulder problems on that same side. So we decided to move forward with a stress test. We did it at Needham. She did what's called an exercise stress echo, which means you walk on the treadmill, and the treadmill gets a little bit faster and a little bit higher every 3 minutes. And we're watching your EKG and your blood pressure and your heart rate. And it's myself or one of my other colleagues or Joe in the room, as well as an exercise technician. And in addition to that, you can have pictures done. And there are two types of pictures. One is the echo or the ultrasound, which takes pictures of the heart, both we have it done before and right after you exercise to see if there are any differences in the pumping function of the heart. Or on the bottom picture, it's showing you a nuclear stress test, where we take nuclear pictures of the heart to see how well the blood is perfusing to all the different parts of the heart. And again, that's done both before exercise and after, so we can see if there are any differences. Next slide. So Susan's stress test was very informative. So she was on the treadmill for 6 minutes, which was kind of average for a woman of her age. She developed the same right-sided chest and shoulder pain at 4 minutes of exercise, and it continued to get worse until 6 minutes. The test was actually stopped because her discomfort was so severe. And she developed abnormal EKG changes during exercise, and they took about 20 minutes before they went away, which is that's a long time. Sometimes we'll see abnormalities go away within a minute, sometimes within 8 minutes. 20 minutes is a long time. And then this is a picture of an abnormal EKG. You see right after the big spikes, the next part of it is down and sloping downwards, and that's the abnormal part that we're looking at. And it doesn't tell us where the blockage is necessarily, but just it's very suggestive that there is a blockage or more than one somewhere. And the echo portion of the test, the ultrasound that she got right before and right after, looked normal. So out of these 3 parts of the test, 2 of them were abnormal. And that was, she got the same pain during exercise and it went away when she rested. That's very common and sort of classic for angina, meaning your heart's not getting enough blood when you're exercising. And then the EKG was also definitely abnormal. So that was the second part that was abnormal. And then the echo portion was normal. So when we get stress tests like that, where because there are different parts of the test we're looking at, not all of them are always normal or abnormal. We have to kind of think about, what do we think of the whole picture of the patient and their symptoms and their risk factors and all the parts of the stress test. And so in this case, I was pretty sure, based on what I was seeing, that she did have a blockage somewhere. Next slide. And so we went to have we had her do a cardiac catheterization, which is also called an angiogram. And this is the invasive test that Joe was talking about earlier, where you have an IV put in one of your arteries, normally in the wrist, but sometimes they use the groin, and then little tubes and wires are snaked up from there up to the arteries that supply your heart. And then on this picture, this is actually the kind of picture that they get. They're injecting X-ray dye down the tubes, and the X-ray dye is black. And so then you basically see the outline of all the tubes. It's like a big plumbing system that supply blood to the heart. And so you can see if there are any, taperings or narrowings of those tubes. So she was found to have a blockage in one artery that was too small for a stent. So it was a smaller artery. It was less than 2 millimeters in diameter. The stents don't go that small. And even if they did, it would be, because it's such a small diameter, it would be unlikely that the stent would stay open. So it was felt she was best treated with medication. And so I started her on a number of different medications, and currently her symptom, the right arm and right chest discomfort, is 90% improved. She occasionally gets it, but in general, it's not there anymore. And we continue to work on her risk factors, her blood pressure and her weight and cholesterol and exercise. And it's actually has been 10 years. I looked back, I saw her in 2011 and saw her again just this spring, and she hasn't had any events. She's not needed any catheterizations, and she's doing great. So there are lots of different ways that we end up both assessing and treating coronary disease, which are very, specific to an individual, their history, their story, and then what we ultimately find. And I think that's it.
Fabulous. Thank you so much, Anne.
Sure.
I really appreciate the personal story. Sounds like too flip description, but they bring obviously home all that we're talking about, and all the big words sort of come together in these real people. And that's one of the things I love about BID Needham, is that is the treatment of people as if they're part of the family. And so that comes through really strongly in both what you were sharing and what Joe was sharing as well. So I am going to do my absolute best to have Anne and Joe answer as many questions as possible. Try and be patient. Please add to the chat if you have not posed a question, you have a question. We will give you a chance to reach out to a member of staff who could forward questions if we don't get to your questions. So just try and be a little patient, because there's a lot of great information here. I do have something for, this could be for Anne or Joe or both. But one question that we received during registration was, have there been any heart-related issues related to any of the COVID-19 vaccines? And I'll just sort of add on to that a little bit, have there been any cardiology related, specifically related questions or answers that have been found during COVID? Has that affected cardiology other than how it's affected the entire hospital?
I can take that one. So as far as the vaccine, there haven't been any cardiac specific adverse reactions that have been tied to the vaccine. There's been some suggestions, some of you might have heard, we don't use the AstraZeneca vaccine here in the United States, but there have been some, you could consider this cardiovascular. There's been some reports of blood clots after getting the AstraZeneca vaccine, but upon review, it doesn't appear that those blood clots were any more than what would happen in the kind of baseline background. So it's, their monitoring boards and all that have felt that, okay, it's probably safe and it's probably not due to the vaccine. Some people are still electing not to, and some countries are electing not to give the AstraZeneca because of that. But here in the States, between Pfizer and Moderna and J&J, we haven't seen any cardiac specific vaccine related things. There are, potential cardiac complications from COVID. You can get what they call myocarditis, which is inflammation of the heart. So, the primary effect is on the lungs, but you can have other organ systems involved, including the heart, and you can develop inflammation of the heart and heart failure, which is a serious complication. But
Thank you. Thank you. Anne, I think this one is for you. What is the latest research regarding the dangers or side effects of taking statins over a prolonged period of time? And this questioner said over 10 plus years.
Yeah, that's a great question. We get a lot of questions about statins in our clinic, not surprisingly, given that we prescribe a lot of statins in our clinic. And, the risks of statin use are small, but they do have some potential side effects. Fortunately, those side effects do not appear to be additive over time. So there are some medications that if you take them for years and years, your likelihood of having a side effect is higher. Statins have not shown that to be the case. Most of the time, the potential for side effects with statins, if you're going to get one of those, it's usually within the first weeks or months of treatment. Now, it's always possible to get a side effect, after you've been on it for years and years, but your risk of getting a side effect does not increase the longer you're on the drug.
And the best evidence we have for that is that, lovastatin has been around since the mid 80s. So we now have a statin that's been around for over 40 years, about 40 years. And there's nothing late that we're seeing, like people are developing cancer or some other complication from being on it for greater than 30 years.
Great, thank you very much. We have some very educated listeners, and so there are some specific questions, but one that's come up a few times that's a little bit more general is about healthy diet and healthy eating for heart health. So maybe I'll pose this one to you, Anne, which is, oftentimes we hear that a healthy diet and not drinking any alcohol is good, but sometimes you can still have high triglycerides. Is there anything there that we should take away from heart health? And then also some questions about low fat versus low carb diets and how those can sometimes not be the most heart healthy, but are better for weight loss, which is obviously helpful. Weight loss is helpful for your heart health. So any thoughts on diet and alcohol consumption?
Sure. So there are a number of questions there. So let me try and sort through them. So alcohol actually in moderation is not bad for your heart health. So at about half a drink a day, it actually can be helpful in terms of prevention of heart disease.
This is the best news I've heard
I
all
know,
the whole day. So thank you.
we
Got my
never-
doctor told me to drink.
I have to, right. So that's why we don't advise it, because you never know what people's underlying family histories are, tendency towards dependence or alcohol abuse. So, but you know, the sweet spot seems to be at half a drink a day. In terms of diet, the healthiest heart diet is actually a vegan diet. So, you know, in general, animal-based food is not great for your heart. You know, I very rarely have patients converting to vegan after being diagnosed with coronary disease, but we do talk about, you know, that red meat is particularly not great. You know, even chicken, any of the sort of animal proteins are tough. So you want to kind of limit that. Fish is good. Fish in general has those omega-3s that are very healthy for you. And so I kind of help guide people through what they can figure out is a good diet for them that they are happy to live with, you know, that they don't want to completely, you know, ruin their day-to-day lives with eating food that they don't like. And then the question about triglycerides. So triglycerides are a risk factor for coronary disease. And so it's important to pay attention to triglycerides as well as LDL. And the things that raise triglycerides are things like blood sugar being out of control. For example, if you have diabetes, drinking a lot of alcohol, and so, you know, not exercising very often and being overweight. And so it is important, in addition to looking at your LDL, you look at all the different parts of the cholesterol panel.
Just a little sub question when we were discussing one of the case studies, is it unusual to have a low HDL when you're a relatively physically fit person? That was one of, I think, Mark's markers there, and that was a question that came up.
Yeah, so exercise can actually raise your HDL, but usually a low HDL is a genetic condition. It's most likely, we see this commonly in families, or also it goes along with people with high triglycerides. So that was probably a genetic factor. And if he didn't exercise as much as he did, he'd probably be even lower. So usually we say that you can raise your HDL by 5 to 10 points if you exercise. So
Great. Thank you. This one, I think that I had Ann's name next to, and I apologize if I'm not saying it right, but we had some questions about SCAD and tachystubocardiomyopathies, and whether the emergency department at BID Needham is educated on those two particular things, and also the cardiology department.
Yes, so a great question. I'll first just explain to the group what those two things are. So SCAD is short for spontaneous coronary artery dissection. That is a rare cause of a heart attack. So it occurs in about 0.5 to 1% of all cases that present, you know, to the hospital with a heart attack, end up being not from a blockage from cholesterol buildup and plaque, but from a dissection of the artery, which basically means the wall of the artery splits. And as it splits, it forms kind of a hematoma, which is sort of a blood collection within the wall, which then pushes into the lumen and causes obstruction. And this, although it's rare, it is much more common in younger people and more common in younger women. So if you have a young person presenting to the emergency room with a heart attack who does not have any of those, you know, traditional risk factors we talked about, you have to, you know, think about SCAD. And I would say that in my, this is much more at the forefront of both emergency room doctors and the cardiology departments nationally than it was 10 years ago. I'd say 10 years ago it was rarely talked about, and now it is a part of training for sure, and much more, people are much more aware of it. particularly in those populations. Takotsubo's cardiomyopathy it's not a heart attack per se. It's an abnormality where it also is rare. It occurs in about 1% of people who show up, and people think, out of a group of patients who show up and people think, oh, they've had a heart attack, about 1% of those people will turn out to actually have this thing called Takotsubo's cardiomyopathy, which occurs when part of the heart is not pumping normally. But when you do the angiogram, all the arteries look fine. There's no dissection, there's no blockage, the arteries all look fine. You can have EKG changes that look like they've had a heart attack. You can have those enzymes abnormal that look like they've had a heart attack. But in fact, Takotsubo's, another word for it is stress cardiomyopathy. Broken heart syndrome is another name for it. And it tends to occur more in postmenopausal women. And it is thought about 75% of cases are induced by either an emotional or a physical major stress. So the reason it was called broken heart syndrome is because sort of the classic is that someone is told that a loved one has died suddenly, and then they have this broken heart syndrome where they, for all intents and purposes, look like they're having a heart attack. They have chest pain. They show up at the hospital. Everyone thinks they're having a heart attack, but then their angiogram looks normal. You can also get it from being very sick from something else. And this sort of complicates that illness. Like if you have pneumonia and you're in the hospital in the ICU with that. So yes, and people get trained on Takotsubo's both in the emergency room, although, frankly, in the ER, what they need to know is that this person might be having a heart attack. Let's get them in and get them an angiogram. And from there, you kind of figure out that it's Takotsubo's. So that one is frankly not as important to have the ER recognize, but the cardiologists are very, well aware of it.
Great, thank you. Thank you. So we only have a couple more minutes. I'm going to try and throw one more at Joe and one more at Anne, and hopefully have covered the bulk of the questions, but there's been some great ones coming in. Joe, are there any baseline tests that you would have? I mean, obviously, Mark thought he was a pretty healthy guy, and he was a really healthy guy from the outside. Were there any baseline tests you would have people who, even if they're not really high on the risk factors, that you would recommend, asking about so that you can have more awareness? And there was also, and I know this is hard to lump in, there's also some questions about aortic stenosis issues, and whether, you wait when you have that, whether you wait also for something to happen before you do something. So yeah, along those lines of prevention and awareness.
Right. So I think with the prevention piece, and, could somebody who's asymptomatic, in their 40s or 50s, is there anything in addition that we should be doing besides what we call traditional cardiac risk factor that Anne pointed out in her presentation? Are there any other tests we should be doing? And this is, it's a hot topic actually right now in cardiology. Should we be doing more? Because we now have these, this CT scan that I showed you. There's a different way of doing a CT scan where you just measure the calcium in your arteries, and as that's kind of a marker that you might have some plaque buildup in your arteries. Mm-hmm. And mm-hmm. The question always is, in what we call primary prevention, somebody who's completely asymptomatic, who doesn't have any symptoms, should we be adding this to the armamentarium of what we do? Over the years, there have been different kinds of tests that people have done, whether it's doing ultrasounds of your carotids, or getting total body scans, or getting ultrasounds and CT scans of different parts of your body. And, there are advantages and disadvantages of doing this in people who don't have any symptoms. Some of the disadvantages is you might find some things that are relatively unimportant, and then you end up chasing after those things and trying to figure out, is this something serious or not? But I would say, as far as, in addition to the traditional risk factors like blood pressure, cholesterol, diabetes, and I do encourage everybody to what we call know your numbers. The American Heart Association is really kind of stressing this. do you know what your cholesterol is? Do you know what your blood pressure is? Do you know what your blood sugar is? Those kind of basic things. Do you know if your weight is in the right range, or is your BMI higher than it should be? So I think knowing your numbers is important. Whether we add this calcium score in addition to that, I think if you're low risk, you don't need it. If you're high risk, like I thought Mark was, then you don't need it, because low risk is going to add. It's really that intermediate risk category, and we are starting to use it more in that situation. And then on the aortic stenosis piece, so aortic stenosis, for those who don't know, is a blockage of the aortic valve. So the aortic valve is the valve when the heart pumps, the aortic valve opens and the blood goes into the aorta and to the rest of the body. And over time, the valve can become thickened and calcified and not open as well. So it becomes blocked, or what we call stenosis. Traditionally, if you have absolutely no symptoms, even if you have up to severe aortic stenosis, we don't treat that. We monitor you very closely. We might even do a stress test to make sure that you're truly asymptomatic and not having any symptoms. But there are categories where if you have very severe aortic stenosis, in other words, the valve is very blocked, that we might recommend you get it fixed, even if you don't have symptoms. But if you have moderate to severe, close follow-up with a cardiologist and echograms every so often is what we do.
Well, terrific. And Anne, we are running out of time, unfortunately. You did touch on women's specific cardiology issues. And so maybe I'll go out on a limb here and invite you and Joe back to talk about specific, issues with women and heart attacks, because I know I'm 53 years old, but a few years ago, my general practitioner said, you should really know what the signs of a heart attack are, because in women they can be different, as you said, and typically women, because they tend to be a lower risk, aren't told that early on, and so they're more looking out for the symptoms in other people. So maybe I think we definitely have enough energy and questions and content there to do this again. So I really appreciate Joe, Anne, thank you so much for your time. Thank you everybody who's been on this call. If you are already a patient in the cardiology department at BID Needham, we want to thank you for entrusting us with your care. And if you are interested in seeing one of the expert physicians there, or understanding anything about any of the services that we offer at the hospital, we'd love to connect you with the best place to connect is through Samantha Sherman. And I think she is going to share, yes, BID Needham External Relations. Alex has just shared Samantha's email address in the chat. And she's also a great liaison with anything related between the community and patients and our clinicians. And so I think without further ado, I will also send you to the bidneedham.org website, which is a great resource. And you can also do a find your physician on that too. I've used that a number of times and it's really helpful. So with that, thank you very much, everybody, for sharing this hour with us. And we hope to see you again soon. Thank you.
Thanks for hosting,
Have a
Sam.
good evening. Thank you.
Bye.